So 6:31, we'll go ahead and get started. So my topic is on ankle sprains. This is a lecture that used to be given by Dr. Fichtel, who, when I was going through some of his slide sets, he had a lot of good points, so I left a lot of them, but did get a lot more updated research with it. So I do not have any disclosures. The most important thing is the CME code, so it's 32026. I'll come back to this at the end, but you have 24 hours to text it to that number. And some of our objectives, we're just going to review the core principles of ankle sprains, discuss the triage of ankle injuries, investigate treatment options, explore prevention strategies. So when I was going through this, just typing in ankle sprains into PubMed was a terrible idea. So it came up, even just within the last year, there's been almost 2,000 papers published. And since the beginning, there's been almost 20,000 papers published. So there's a few people that have a couple ideas on the subject, which kind of can make it a little difficult to sort through. But just general idea, I think everyone knows how common it is. So over 2 million injuries a year. It's one of the most common injuries that's going to bring someone out of a game. So there's roughly 8.3 per 10,000 athlete exposures. So roughly, if you're equating this to like Vanderbilt football, about every 10 practices, someone should sprain an ankle, which personally, after covering, I think it seems a little bit more than that, but and it's a little bit lower at the high school rate. And then as far as syndesmosis or high ankle sprain, it's about 1 to roughly 20% of all ankle sprains. There's a study for NCAA football, and it was about 2.4 per 10,000 athlete exposures, and about 1% in a military study. And there was an NFL study where it was about 22% higher compared to the other studies. And there was a slightly higher incidence with turf in a few of the studies that I looked at, which I don't think is very surprising. So typical ligaments that are involved, we all know this, is just to review. So you have your ATFL, your CFL, PTFL on the lateral side, and then the medial deltoid ligament, and which attached to all these bones, which we all know. So talked about the lateral stabilizers, the medial is the deltoid, and then the syndesmosis is the AITFL and the PITFL and the interosseous ligament. So anteriorly, we have the ATFL. It's greatest in plantar flexion as far as tension, and resists the anterior translation of the talus. It's the weakest one. It's the one that's sprained the most often, greater than 85% in most studies. The CFL, it's deep to the peroneal tendons. It's larger, 2 times stronger than the ATFL in cadaver studies. It resists dorsiflexion and it provides subtalar stability. And then the PTFL, still stronger than the ATFL. It resists the extreme dorsiflexion and some posterior translation. The deltoid ligament, which is medial, it's obviously the strongest. It's difficult to damage this. It resists eversion, external rotation, and plantar flexion. And it has different portions. So, and then the syndesmosis, which we talked about in a cadaver study, the AITFL and the PITFL make up the majority of the forces that resist it, with the interosseous membrane being the least force resistance between them all. And there's more to it than just these ligaments, obviously. There's the biomechanics and proprioception and your peroneal muscles as dynamic stabilizers that are an important part specifically in prevention, which we'll talk about later. So we'll go into a case. You have a 21-year-old athlete, injures his ankle, it's in a game, it's swollen, he's unable to bear weight, comes over to you on the sideline. On exam, he's tender over his lateral mal on the tip and his anterior tip fib. He's not tender over the proximal fibula. He's a negative squeeze and a positive external rotation test. And we did not do his anterior Dworin-Taylor tilt on the sideline. So the immediate questions that you have on the sideline, can he go back in the game, and does he need x-rays? I think a lot of this depends on the level. I would say the high school athletes that I've been covering, pretty much they come out of the game. There's not as much going into it. But with the college athletes, I think a lot of it has to do with are they able to play to that level, even if they want to go back in? Do they have full speed? And all of that kind of has to tailor your decision. So the ever popular Ottawa ankle rules to help us decide if he needs an x-ray. Tender over the posterior edge of the lateral medial malleus within 6 centimeters of the tip, and then base of the fifth metatarsal or any midfoot tenderness over the navicular, as well as they need to be able to bear weight for 4 steps immediately, and then technically an ED, which isn't helpful for us on the sideline. And then I've heard about this, even though I don't personally know Dr. Spindler, but his rules: any history of prior fracture, any pain with external rotation, any pain at the distal mid-tib or mid-fibula. And in this study, it was 100% sensitive. So for our case, he was tender over the malleoli and he had pain with external rotation. So our athlete needs an x-ray. This was an interesting one I hadn't heard about before, called the Shetty Test. In this original study with about 50 patients, all had x-rays. Essentially, you just simulate weight bearing, you put your hand on their palm and they push down, and if they have pain, then you get an x-ray. This was 100% sensitive in the study. It's been since repeated in a few different ED studies with consistent results. I find it interesting because I figure they're not going to be able to put as much weight pushing down on your hand than if they just stand. So I don't really know, for me, if I'm going to use that to change my practice, but I just find it interesting that there are more things out there. So our case, here's images for x-ray since he was tender, and some things that we would look at. So the tibiofibular overlap, so it should be greater than 6 millimeters on AP and greater than 1 millimeter on the Mortise view. And the tibiofibular clear space needs to be less than 6 millimeters. And that's the most reliable in the studies I looked at for a syndesmosis injury. And then of course the medial clear space should be less than 4 millimeters as well. And so you can see that this would obviously be an example of it all being whitened. And so I think that would catch your eye even without measuring it. So back to our case images, doing quick eyeball measurements, looks pretty good. He still can't walk though, so head to the training room to do a better exam. And some of the additional tests that we can do for ankle instability, there's the anterior drawer. The best position is getting your gastroc out of it. So bend the knee to 90 degrees of flexion, plantar flex the ankle at 10 degrees. And no one measurement is more diagnostic than any other. It's, more about how you feel from one side compared to the good side. I think it's going to get you the most accurate test. The anterolateral drawer seems to be a little bit more sensitive because it pivots around the deltoid. And a lot of people use about 3 millimeters of translation is the cutoff point for 100% sensitivity. Another one is the Taylor tilt test. And so for this, you want to have the foot more neutral and then invert it. This is a really good one to compare to the other side as well, just like with all exams. And this would maybe lean towards also having a CFL injury if it is opening up. So what about the syndesmosis? So in a study that had MRI proven syndesmotic injuries, the single leg hop, tenderness, and dorsiflexion and external rotation testing was decent. The squeeze test was the most specific at 88%. Of course, arthroscopy is still the gold standard, but just a combination of all of this is going to be important. Grading scales. So I think the classic grading scale, at least to me, doesn't make as much sense in the immediate phase of being on the field. but classically grade 1 for mild, some fibers are torn maybe, they get back in roughly 12 days versus grade 2 incomplete tears takes a little bit longer versus grade 3 very severe complete disruption, and it can take like greater than 6 weeks. And the best time to grade the injury might be around day 5 to 7, depending on what study you're looking at. I like the functional grading scale. I think it just makes more sense. Essentially like mild, moderate, severe pain, how much are they able to bear weight? It's not so much validated, but to me, it just makes much more sense, and you're able to kind of give it a grade immediately. So who needs more imaging? We talked about, you know, the X-ray, but what other criteria do we have to get more imaging, and what are those images? So you can obviously get stress views, you can get an MRI, you can do ultrasound, and especially as that's become more available. As far as stress views, any study I looked at pretty much showed that gravity stress is equal to manual stress, just having them even stand, or this is a external rotation. And looking for the medial clear space on the stress. You can do tailor tilt and anterior drawer stress views as well, but when I was looking at the studies for that, it's kind of all across the board as far as sensitivities. And so I think that using your physical exam for those, I think is just as helpful. Of course, you can get MRI, which is the gold standard imaging that we could get to see these injuries. It's 100% sensitive, 93% specific for AITFL when I was looking, and it's about 100% for both for PITFL in one of the studies I was looking at. This is a study for ultrasound, 34 patients that had undergone arthroscopy, and ultrasound and MRI were pretty close to being the same, since a lot of these structures are more external and you can see them. But some of these studies are kind of smaller numbers. So for our patient, we have an ankle sprain. What do we do? Following guidelines that we do every day, RICE. So there are many things you can do. Not much data supports a lot of it. NSAIDs have been shown to get back to work quicker compared to others. As far as ICE, there were a few studies, and one of them was like a systematic review showing that, of course, it vasoconstricts, it reduces your metabolic rate, reduces swelling, but it can be harmful in patients, especially if they have neuropathy, and you can have injury if you're keeping it on there for more than like 20 to 30 minutes. And so that's kind of where that number came from. So this was the systematic review I was talking about, going through a bunch of different studies. This is just a couple of them highlighted. The first one was in the ED. It was 116 patients, and they used just 30 minutes of this cooling anklet, and it trended towards like improvement of edema. The second study was 30 students that had a grade 1 or grade 2 ankle sprain in the 80s, and they delayed treatment and there wasn't any benefit. The next study was just cold gel 4 times a day for 14 days, and there was a reduction in pain. That was about 74 patients, less than 48 hours from the injury. And then the systematic review, after pulling all the data together, showed that it may reduce return time back to work or sport. So that's why we do it. Medications, NSAIDs are definitely the mainstay. We all know that. And there are obviously various NSAIDs, and I think it's really about what you're most comfortable with. Oral and topical work, there hasn't been a lot of comparison studies between them, but there's the short-term benefits are reduced pain at rest and weight bearing and decreased swelling, which I think it just makes inherent sense. And so this was a study for Voltaren. It was better than placebo, and it was similar oral to gel, which I thought was interesting. So in my mind, you potentially have less side effects since it's not getting so much systemic. This was another interesting like topical called Tramil. I've never heard of it, never used it before. There was a ton of studies just coming out on this recently where they're using it for everything that has to do with inflammation, but particularly this study used it versus diclofenac gel for reducing pain and ankle mobility after an ankle sprain, and they blinded them, and it was equivalent. So I thought that was kind of interesting. So I'm gonna look into it a little bit more. I'm sure it's outrageously expensive. So kind of getting into other things
Hey,
for
Zach.
treatment.
Zach,
Yeah.
I was just going to say, I looked that up, and it's homeopathy. So
Yeah,
I wouldn't go too far down that path.
I don't. Yeah, I agree. Like all the stuff in it is a bunch of herbs, but there's been more and more kind of randomized trials. So I just found it kind of interesting. Normally, I didn't get too much into the study into the designs, but I just thought it was interesting. But yeah, I don't think it's going to be a cure-all like most things. And so other things, as far as treatment, this study randomized the patients to get either four immobilization techniques. So either a short cast, a boot, air cast, or just this compression squeeze. And the one that had the best results was actually the short leg cast for about a week. There was definitely a lot of issues with this study. So after randomizing and telling about 79 of the people that, hey, you're going to get a cast, 46 of them said no, and they exited the study. So 62% would not actually go through with it. And the mental health scores for the people with the cast was statistically lower as well. So that's just something to think about. And obviously, no one wants to wear a cast if you don't need it. And the one that did the worst was the sleeve. So just as far as kind of further going into that study, the cast initially did the best. The compliance throughout the study was kind of hard to follow. They didn't have any re-injury data, and they didn't have any post-injury protocol. And they also didn't compare it with functional treatment at all, like an ASO, which is obviously something that we do a lot. So this is a study comparing a walking boot to functional or an ASO with MRI-proven tears. Functional ended up with just generally doing better pain and functionality. They got to work quicker. This was a Cochrane review. So I think this is probably one of the reasons why we do functional more than anything else. Other things to do is physical therapy, focusing on strength and neuromuscular control early on. And especially grade 1 and grade 2 sprains had better outcomes if you did it early compared to waiting. There are other things. So this is just an online resource that I found that if the patient maybe doesn't have the money to go to PT or the time, you can give them this resource. It's just orthoinfo.org, and it has more on strengthening and stuff. It doesn't have as much on balancing and proprioceptive, so that would need to be added. So some other treatments that we could do, injections. There haven't been a lot of studies that I saw on glucocorticoids. There was a study on hyaluronic acid in 158 consecutive athletes with grade 1 or grade 2. They injected days 0 and 4 compared to placebo. There was better pain with weight bearing that they considered to be clinically and statistically significant in the intervention group. And as far as like other injections, I know that, it's pretty common to numb a patient up, especially at the higher levels, to get them through the game. Found some studies on PRP. So this one was a positive study, specifically for high ankle sprains and elite athletes. So 16 athletes with ultrasound proven AITFL injuries. They were randomized to PRP versus placebo. And then the results were the PRP group returned to play about 19 days sooner, and much less of them had residual pain. I would say this is a low number of athletes, so it was only 16. And so I wouldn't say this is practice changing, but that's one of the positive studies. Kind of trending off that, this is actually an emergency medicine study, which I was surprised they did. It was a double-blinded, randomized, placebo-controlled, and they did PRP for acute ankle sprains in the emergency department. They enrolled 37 people. 4 of them withdrew before the injection when they found out they were going to get a shot. 18 ended up getting PRP and 15 got placebo. It was about 7 emergency medicine docs that were all trained beforehand with ultrasound and PRP to keep it a little bit more consistent. And they got their pain scores at 0, 3, 8, and 30 days. And they couldn't have a fracture on x-ray, of course. And the thing that I thought was interesting on this study is if they didn't know what was wrong, so if they didn't have like an actual injury, they would just kind of inject at the point of maximal tenderness if nothing was seen on ultrasound. And the study was overall just kind of underpowered and had a low number of participants, but they didn't have any significant difference between the PRP and the placebo group. But overall, I think that study kind of had a lot lacking. Some other things, of course, there's acupuncture and other homeopathy, not a lot of evidence, and there's been a lot of poor studies. Surgery obviously would be the next step, and mostly for like chronic recurrent ankle instability that's failing recurrent or conservative treatment. This study was a Cochrane review in 2007, reviewing 20 studies of over 2,500 patients. And the initial review showed statistical improved return to sport and less subjective functional instability. But when you removed one of the poor studies, then there wasn't really a difference. And so not a lot of conclusions could be made. And like 15 of the 20 studies that were used in this were over 20 years old. And these patients were casted for 6 weeks after surgery, which is just something you have to think about. This was a finished paper. It was randomized for grade 3 sprains with 51 patients and only 65% follow-up. And there was no difference to return in pre-injury activity or really any of their metrics. And there was a higher prevalence of re-injury with the functional group that did not get surgery. But overall, there's a higher prevalence of osteoarthritis in the surgical group. I mean, the numbers were low, so kind of take with that what you will. But this is another one, a Japanese study in 2012, functional versus surgical. And the functional group had about a 10% failure rate, but they were back to sport in about 6.3 weeks with support or 16 weeks without, versus surgical, which had their main failure was about 10% had superficial peroneal nerve pain, but they got back faster with support and without compared to the functional. They also, I would say in that study, they were doing kind of intense rehab and physical therapy within 2 days after surgery, which I think was pretty aggressive and maybe difficult to do. So who gets surgery? Is it the severe injury in a high athlete? I think that, at least for me, when I was looking at the studies, I think the jury's still out. I don't know kind of I haven't been around here long enough to know the practice pattern or you know, anecdotally, you know, who seems to do better, but it didn't seem like a very obvious answer when I was looking at the data. As far as syndesmotic injuries with surgery, grade 2 is what I was saying that you could consider. In grade 3, if there's frank diastasis. A couple surgeries that I was looking at is the endobutton versus screws. And I saw the screws, there was like a 3.5 millimeter versus 4.5 millimeter, and going through like 3 versus 4 cortices. I didn't see a lot of good studies. It seemed like, as far as like going between any of these, it seemed more expert opinion. And it seemed that most of, as far as the screws, had similar outcomes. As far as the endobutton, the study showed there wasn't any difference in the non-randomized comparison compared to the screws with the Endobutton. This was one of the first studies to compare it, and what the Endobutton people are saying is, we don't have to remove any hardware, and so this is better, it's more functional. But then there was a separate case series that showed 2 out of the 6 had to be removed due to like soft tissue irritation, or so maybe not as good as they initially thought. So this was another one regarding the tightrope Endobutton. It was a 2-year follow-up showing that the reduction was maintained. They had earlier weight bearing, but there still was some complications where they did have to remove still a decent number of them. So I don't think it's the perfect thing like they were originally thinking. What is the, I don't have any personal experience with this here. Would any of the surgeons, could you guys speak to like which you would prefer, or kind of your thoughts on them?
I don't know if Jaron's on the call, but he has some experience doing the Endobutton technique.
Yeah. I'm on here today.
Yeah.
So as far as Endobutton,
We lost you, Jaron. Jaron, you're on mute.
can you hear me now? Sorry about
Yeah.
that. Okay. I think the big advantage of the Endobutton is obviously not having to remove it, and it doesn't seem like most of these patients get very irritated by the button. If they are irritated by it, it's very simple to take it out. Whereas if you put a screw in, it's gonna either break or you gotta have a plan to take out. And if it breaks, then you just have the cosmetic aspect of looking at a broken screw.
Mm-hmm. Yeah. After kind of what I was looking at, I think if I was dealing with this, I think I would prefer the Endobutton. But
Most of the time, I think the trauma doctors that are dealing with, they almost all do screws, and
okay.
they're dealing with really high energy fractures, like complete diastasis of the tibia and fibula. And on the other hand, like a lot of the sports doctors, we're dealing with low energy, like they went to the ER, they were sent out, they show up in clinic, or they just show up in clinic because it hurts, but it wasn't that severe. And so I also think like the tightrope is probably perfect for like the lower grade injuries. But if you had like high level diastasis or something, then it'd probably be a lot better to use the screws.
That makes sense. Yeah. Thank you.
Zach, hey, it's Charlie.
Yeah.
One thing I want to add just with Vandy football and the trends, and Jaron can possibly comment as well. I think ever since the Tua situation came into play, for these high-level syndesmotic injuries, in my experience, that normally manifests as inability to bear weight on the field.
Mm-hmm.
There is a trend more towards tightroping those to try and improve the time frame for return to play. So I think I would keep in mind if you have someone that you suspect has a very high-grade syndesmotic injury. I know our trend is if they can't bear weight to consider tightrope fixation, which I think is definitely something that's changed over the last 2 years. Taking a potentially 6-week injury and converting it possibly to a 2 to 3. And Jaron or Eric may be able to comment more since they're still doing those surgeries.
I just had a patient, I guess about 6 weeks ago, as a high school athlete. He's a senior. He had a pretty classic high ankle sprain, and he's the quarterback, and he's kind of in a position where, this is his last chance to get seen, and he's got schools wanting to look at him. And so we had a discussion about it, and I did a tightrope on him. And he bounced right back. I mean, he literally couldn't. I mean, he was limping on it significantly. And then at 2 weeks, he felt ready to play, but they didn't play him until 3 weeks. And then he was able to finish his season. So it can definitely accelerate. And he had a very high grade injury in terms of I thought it was a borderline syndesmosis. His anterior inferior tib fib was completely disrupted, and then posterior the ligament was intact, but he had a non-displaced fracture of his posterior malleolus, and it seems like either they'll get like edema in that posterior malleolus, or they'll have like a non-displaced fracture. Those are pretty common findings in kind of the high ankle sprain group.
Yeah, thanks for adding that. That's stuff I would never be able to find. So as far as overall prognosis of just generally ankle sprains, this was a systematic review of 24 high quality studies. Most people have rapid decrease in pain within about 2 weeks of their ankle sprain, kind of regardless of what it is. About 5 to 33% still have pain at 1 year. And about a third will have a re-injury and with the highest risk within 1 year. And about 85% of most people have full recovery at around 3 years. So I think that fits kind of what we see. It seems that increased laxity measurements doesn't really equal increased ankle sprains in the future. And in high school, new versus recurrent didn't really affect the return to play. So kind of despite it being like the first ankle sprain or a recurrent, most will still back to play within about 3 days roughly. And it seems that severity on MRI doesn't seem to correlate necessarily with the patient's symptoms all the time. And as far as prevention, this was a study done for volleyball players at one university, and where their injury rate was maybe a bit lower than the average. There's been kind of multiple showing kind of braces essentially, they definitely help with recurrent ankle sprains. I think that is like overwhelming evidence, kind of going through a bunch of these studies, and have the really good ability to decrease a lot of injuries. In most of the studies I was looking at, the ankle bracing and taping were about the same. Braces, of course, are cheaper, less materials that are going to be used, and it's going to prevent a lot of recurrences with pretty minimal intervention, which I think that's why we tape every Vandy football player before every practice and game, which makes sense. I think a lot of this should be coupled with neuromuscular training. There's a lot of studies showing that the proprioception training, the strengthening, can be just as effective, but they have to keep it up though, which I think the reality is a lot of people will do that training, they'll get strong, and then they'll stop doing it. And then later on, they have essentially the same ability to injure it later. So this was a systematic review of kind of all things ankle sprain and all of the treatments in 2017. And this was kind of showing the same thing those other studies did, that bracing definitely helps with secondary prevention. There's a trend towards primary, but more data was needed. Taping, there were 2 studies in this that were inferior, but most of them were about the same. This also, in this systematic review, mentioned shoes, high top versus low top, and it seems kind of to be conflicting. There doesn't really seem to be a difference, or there just honestly needs to be more studies regarding it, but there's no real answer for this yet. But I would say, we have good data showing that, taping and ankle braces work really well. So I think that that's something that we should use. So in summary, we all know how common these are. They all come in different flavors. You can immobilize. You can immobilize the severe injuries, and there's a trend towards them getting better quicker, but then they have to be in a cast. Ice is good, NSAIDs are also good, which we all know. physical therapy or just really getting them moving early with proprioception and balance training are really helpful. I think we kind of answered today that those high-grade syndesmotic injuries probably would benefit a little bit better compared to other surgeries. But I think that there's still a lot of questions out there. And bracing is definitely good for secondary prevention, and especially with physical therapy. And so I would, if it were me and I did when I was playing basketball, once I finally started wearing ankle braces, I stopped spraining my ankles, and then I got to play more, which was great. So I finished a little early. I don't know if we can talk more if anyone has any questions about anything in particular. I'll go back to, let's see.
Hi, I'm a physical therapist at the Osher Center.
Yeah.
And I actually used to work in lymphedema, and I saw that you had the compression garment study, but actual short stretch bandages can be helpful to reduce persistent edema.
Yeah, I think that's great to kind of bring up. I think that most of the stuff that I was kind of talking about was more about, I think, functional and getting people back, and but that is definitely kind of an element that I didn't really talk about a lot, is just the persistent swelling. So that's a good thing to bring up.
And I think the big thing is you don't have to have lymphedema to send someone to the lymphedema clinic. You could just have persistent edema, and they can usually reduce it within about 2 to 3 sessions.
That's great. What's the best way to refer someone to that clinic?
The Dione Center?
Okay. Thank you. All right. So there's the code again. Give another 10 seconds if anyone else has any other questions or comments, but otherwise you can just enjoy breakfast before clinic. All right.